Welcome to the deep dive. Today, we're getting into hypoparathyroidism. It might seem a bit niche, maybe, but understanding it is really key.
Definitely.
Think of this as your focused revision session, high yield, hitting all the essentials you need to know.
Exactly. We've boiled down the key info on hypoparathyroidism, what it is, causes, how it works, what symptoms to look for, diagnosis, treatment,
Mm-hmm.
the works. Trying to make it, clear and stick in your mind.
Great. So let's kick things off. What exactly is hypoparathyroidism?
Okay, so basically it means your body isn't making enough parathyroid hormone, PTH, or maybe the body can't use the PTH it makes properly.
And PTH is the calcium regulator.
That's the one. PTH is absolutely vital for controlling calcium levels. It helps you absorb calcium from your food with vitamin D's help, of course. It tells your kidneys not to pee out calcium, and it signals your bones to release a bit of calcium into the blood if needed.
Okay.
Oh, and it also helps get rid of excess phosphate.
Right. And this PTH comes from those four little glands behind the thyroid.
Yep, the parathyroid glands tucked away back there. Now, things get a bit more detailed because there are different sort of flavors of hypoparathyroidism.
Ah, yes. Primary, secondary, pseudo. That sounds potentially confusing. Can we break those down?
Let's do it. So primary hypoparathyroidism, think of this as the source problem. The glands themselves just aren't making enough PTH.
Okay.
And the number one reason for this, damage or removal during neck surgery, especially thyroid operations.
Right, makes sense.
Biochemically, this means low calcium, high phosphate. And the treatment often involves alpha-calcidyl. That's an active form of vitamin D.
Got it. Primary gland problem, often post-surgery. What about pseudo-hypoparathyroidism? That sounds, well, pseudo.
Huh. Yeah, it's a bit of a curveball. In
Yeah.
pseudohypoparathyroidism, the parathyroid glands are actually working fine. They're churning out PTH, sometimes even too much.
So what's the issue then?
The problem is resistance. The body's cells, the target cells, aren't responding to the PTH signal properly. There's usually an issue with something called the G protein, part of the cell's signaling machinery.
Ah, so the message isn't being received even though it's being sent loudly.
Exactly. People with this might also have other features,
Yeah.
like sometimes a lower IQ, short stature, maybe characteristically short finger bones, metacarpals,
And the blood tests?
low calcium, high phosphate, just like primary. But here's the key difference.
Mm.
The PTH level is high. The body's trying desperately hard, but the signal's blocked.
Okay, that's a crucial distinction. High PTH points towards pseudo.
Right. And then, just to complete the picture, there's pseudohypoparathyroidism.
Seriously?
Yep. These people might look similar. They might have some of the physical features of pseudohypoparathyroidism, but their calcium, phosphate, and PTH levels are all completely normal. It's the look without the biochemical problem.
Okay, wow. So summing up the key blood results. Standard hypoparathyroidism is low calcium, high phosphate, low or maybe normal but too low PTH. Pseudohypoparathyroidism is low calcium, high phosphate, but high PTH.
You've got it.
So what kind of things actually cause this? What's the etiology here?
We can think about causes as either primary or secondary. Primary causes, as we touched on, directly affect the parathyroid glands themselves.
Like the surgery.
Exactly. Surgical damage during neck procedures is the big one. But autoimmune disease can also be a primary cause where the immune system attacks the parathyroid glands.
And secondary causes, that's more indirect.
Right. Secondary causes are things that interfere with PTH function or production. A really important one is severe magnesium deficiency. Magnesium is crucial for PTH release.
Ah, okay. Didn't know that.
Yeah, it's key. Also, radiation therapy to the neck can cause damage over time. Then there are certain genetic conditions and some rare diseases where substances infiltrate and damage the glands.
The notes also mention different timings, like transient versus congenital.
Yes, good point. It can be transient, maybe temporary after surgery, then it gets better. It can be congenital, meaning present from birth, often due to genetic issues like DiGeorge syndrome or specific gene defects affecting calcium sensing or PTH action.
Or required.
Or acquired later in life that covers the surgery, radiation, autoimmune causes, magnesium issues, drugs, infiltrative diseases we talked about. And we should probably mention neonatal causes too, like prematurity or maternal diabetes can sometimes affect a newborn's PTH temporarily.
It's quite a range. So thinking about who's more likely to get this, what are the main risk factors we should flag?
Well, they pretty much mirror the causes. Top of list, a history of neck surgery, particularly thyroid or parathyroid surgery.
Definitely.
Then radiation therapy to the head or neck region. Also having certain genetic disorders like DiGeorge syndrome or autoimmune conditions like autoimmune polyendocrine syndrome type 1.
Any others?
Certain medications are sometimes implicated, like bisphosphonates in some contexts, though that's perhaps less direct causation. But surgery and radiation are the big ones to remember.
Okay, so someone has one of these risk factors, their PTH drops or stops working. What's actually happening inside the body then? The pathophysiology.
Right, the core issue is simple. Less PTH action means less calcium in the blood hypocalcaemia and more phosphate hyperphosphataemia.
And that's because PTH normally boosts calcium.
Exactly. Let's quickly run through the normal balance. Think of calcium regulation like a three-way conversation between your intestines, kidneys, and bones, with PTH, calcium itself, and active vitamin D as the main messengers.
Okay.
Vitamin D helps your gut absorb calcium. PTH does three main things for calcium. Tells bones to release some, tells kidneys to activate vitamin D, and tells kidneys to reabsorb calcium. It's all about raising blood calcium.
Yeah, there's a feedback loop.
Yep, a negative feedback loop. High calcium tells the parathyroids, okay, chill out, less PTH, please. Low calcium says, help, more PTH.
Right, and phosphate.
PTH tells the kidneys to get rid of phosphate. So when PTH is low, the kidneys hang on to phosphate and levels in the blood go up. Hypoparathyroidism basically disrupts this whole finely tuned system. The conductor, PTH, is missing or ignored.
So the orchestra is out of tune, low calcium, high phosphate. Okay. Now, if someone presents with symptoms that make you think low calcium, what else might be going on? What are the main differential diagnoses?
Good question. It's crucial not to jump straight to hypoparathyroidism. You have to consider other possibilities. Pseudohypoparathyroidism, as we discussed, is key. Same, low calcium, high phosphate, but high PTH.
Right, the PTH level is the giveaway there.
Definitely. Then there's vitamin D deficiency. That can cause low calcium too, but usually the body tries to compensate, so PTH levels would likely be high, not low.
Ah, okay. So PTH goes the other way.
Generally, yes. Chronic kidney disease is another big one. Kidneys are vital for activating vitamin D and handling phosphate, so CKD really messes with calcium balance, often leading to high PTH, which we call secondary hyperparathyroidism.
So again, high PTH.
Correct.
Yeah.
And finally, there are various rare genetic disorders that directly affect how the body handles calcium and phosphate. But checking PTH is often the first major branching point in figuring it out.
Makes sense. Is hypoparathyroidism common? What's the epidemiology like?
It's actually considered a rare condition.
Okay.
It can occur at any age. Some cases are congenital, but most are acquired, often, as we keep saying, after neck surgery.
Yeah.
Because it's rare, it might not be top of mind, but the consequences of missing it can be significant.
Right. So what are those consequences? How does it actually present? What are the clinical features?
The symptoms are mostly driven by the low calcium, the hypocalcaemia. They can be quite wide-ranging. People often report things like muscle cramps, muscle twitching, maybe that tingling or pins and needles feeling, especially around the mouth or in the fingers and toes. That's called paresthesia.
Okay. Anything else?
Yeah. Over the longer term, you might see changes like dry skin, brittle nails, maybe some hair loss. Dental problems can occur and cataracts can develop in the eyes. And interestingly, low calcium can affect the brain, leading to things like anxiety, depression, and in severe acute cases, seizures.
The notes had a mnemonic for the really acute symptoms. Cats go numb? That sounds useful.
It is. It's a great way to remember the serious signs of hypocalcaemia. So C is for convulsions or seizures. A is for arrhythmias, abnormal heart rhythms. T is for tetany, that's the involuntary muscle twitching and spasms.
Okay.
S is for stridor and spasms, specifically laryngospasm, where the voice box spasms, which can dangerously block the airway. And the go numb part reminds you of the numbness and tingling, especially the perial paresthesia around the mouth.
Cats go numb, convulsions, arrhythmias, tetany, stridrospasms, and numbness.
Got it. Are there specific signs a doctor might look for on examination?
Yes, two classic ones. Trousseau's sign. You inflate a blood pressure cuff on the arm for a few minutes, and if the hand goes into a specific spasm, wrist flexed, fingers together, that's positive.
Okay.
And Schwastek's sign. You gently tap over the facial nerve just in front of the ear and look for twitching of the facial muscles on that side.
Right. And ECG changes.
Yes. Importantly, you look for a prolonged QT interval on the ECG. And it's worth repeating, severe hypercalcemia can be life-threatening due to those cardiac issues, laryngospasm, or seizures. And sometimes the symptoms might hint at the underlying cause.
Exactly. If it's part of DiGeorge's syndrome, you might see associated features like heart defects, immune problems leading to infections, maybe characteristic facial features, speech delay. If it's APSI, autoimmune polyendocrine syndrome type 1, look for chronic mucocutaneous candidiasis, fungal infections, plus adrenal problems, vitiligo, dental enamel issues,
Okay.
and other genetic syndromes might have associated deafness or kidney problems or learning difficulties. So the whole clinical picture is important.
Right, it's not just the calcium. So how do we confirm the diagnosis definitively? What investigations do we need?
Blood tests are the cornerstone. You absolutely need to measure serum calcium adjusted for albumin or ionized calcium if possible, which will be low, measure phosphate, which will be high, and crucially measure PTH, which will be low or inappropriately normal for the low calcium level.
Well, that
You'd usually check vitamin D levels as well, and alkaline phosphatase, which is typically normal in hypoparathyroidism, unlike some other bone conditions. You also need to check magnesium because low magnesium can suppress PTH release and needs correcting first.
makes sense. Any other tests that might be helpful?
Depending on the context, yes. Kidney function tests, UNEs, creatinine are essential to rule out CKD. An ECG to check for that prolonged QTC, maybe urine tests for calcium excretion, though that's more for monitoring treatment sometimes,
Imaging.
possibly. An echocardiogram if there are cardiac concerns. A renal ultrasound to look for kidney stones or calcifications. If you suspect pseudohypoparathyroidism, a hand X-ray might show those shortened metacarpals. Maybe a brain MRI or CT looking for basal ganglia calcification in long-standing cases, and genetic testing if a specific syndrome is suspected.
So a targeted approach based on the presentation. What are the absolute diagnostic criteria then?
Essentially, you need confirmed hypocalcaemia with an undetectable or inappropriately low PTH level after you've confirmed magnesium levels are adequate. It's also good practice to screen for related autoimmune conditions like thyroid or adrenal problems, especially if you suspect an autoimmune cause.
And the PTH level really sorts out from pseudohypoparathyroidism.
It's the key differentiator, yes.
Okay, so we've diagnosed it. How do we manage hypoparathyroidism?
The main goal is to relieve symptoms and bring calcium and phosphate levels back towards the normal range, or at least a safe range.
And how do we do that?
The standard treatment, the conventional therapy, is calcium supplements and an active form of vitamin D. Usually this means calcium carbonate or citrate, plus alpha-calcityl or calcitriol. These active vitamin D forms bypass the need for kidney activation, which is normally stimulated by PTH.
I guess getting the dose right is tricky.
Very. That's why regular monitoring of blood calcium and phosphate levels is absolutely critical. Many things can affect requirements. Diet, sunlight, other illnesses. It's a constant balancing act. For really severe, acute symptoms like tetany or seizures, you need urgent IV calcium in hospital.
Any dietary advice?
Yeah, recommending a diet reasonably high in calcium can be helpful, though supplements are usually still needed. Limiting high-phosphate foods might also be advised, and sometimes other meds might be needed, like thiazide diuretics, to help reduce calcium loss in the urine.
What about replacing the missing hormone itself, PTH therapy?
That's becoming more of an option, yes. Recombinant PTH, teriparatide, or longer-acting forms can be used, particularly in cases difficult to control with conventional therapy, or to try and reduce the long-term risks associated with high doses of calcium and vitamin D, like kidney stones. It aims for more physiological control but requires injections and careful monitoring.
So supplements are the mainstay, but PTH replacement is an evolving option. What's the long-term outlook, the prognosis?
It really varies depending on the cause and how well the condition is managed. But the good news is that with careful, consistent treatment and monitoring, most people can lead a pretty normal life.
So it's manageable.
Yes, generally. But it does require lifelong attention and regular checkups, often managed collaboratively between specialists and the GP.
That regular monitoring sounds key. What happens if it's not well managed? What are the potential complications?
Right, untreated or poorly controlled hypoparathyroidism can lead to problems. Chronic low calcium and high phosphate can cause calcifications, calcium deposits in soft tissues. This can happen in the kidneys, leading to kidney stones or nephrocalcinosis, potentially impairing kidney function over time, and even causing chronic kidney disease.
Calcification in the brain, too.
Yes, basal ganglia calcification is a classic finding in long-standing cases, though it doesn't always cause obvious symptoms. There can also be effects on bone health, potentially leading to a higher fracture risk paradoxically, even though bone density might sometimes seem high.
And the acute risks.
The acute risks of severe hypocalcaemia are the most dangerous. Seizures, life-threatening cardiac arrhythmias, and laryngospasm causing airway obstruction. Those are medical emergencies.
Any other long-term issues?
Neuromuscular irritability with cramps and tetany can be ongoing if not well treated. In children, untreated hypoparathyroidism can lead to impaired growth and potentially affect mental development. And we also have to be careful not to overtreat with vitamin D, as that can cause hypercalcemia and kidney damage too. It's all about finding that balance.
It really highlights the need for that careful, ongoing management. Okay, let's try and bring this all together. What are the absolute key takeaways for hypoparathyroidism?
Okay, so remember, hypoparathyroidism means too little or ineffective PTH, causing low calcium and high phosphate. Think surgery first for primary causes, but remember autoimmune and genetic links too. Distinguish it from pseudohypoparathyroidism.
Yeah.
Check the PTH level. High PTH despite low calcium means pseudo. Symptoms are mainly due to low calcium. Remember, cats go numb for the acute signs. Convulsions, arrhythmias, tetany, stridor spasms, numbness. Diagnosis relies on low calcium, high phosphate, and crucially low or inappropriately normal PTH with normal magnesium.
And management.
Management is calcium and active vitamin D supplements with very careful, regular monitoring. BTH replacement is an option in some cases. It's rare, but recognizing and managing it well is vital to prevent serious short-term and long-term complications.
Right. It really is striking, isn't it? Considering how finely balanced calcium regulation is in the body, it makes you wonder, what other seemingly small hormonal imbalances can have surprisingly widespread effects? Something to think about.
Absolutely.
And on that note, if you are revising and want more excellent resources, definitely check out pastmsra.com and also freemsra.com. They're fantastic tools for getting exam ready. Thanks for joining us for this deep dive into hypoparathyroidism.